Assalamu alaikum. My name is Khadija Naz and my roll number is BP1650105. The topic of my presentation is clomiphene. Before going to start the case study, we should know that what is clomiphene drug and what are its contraindication, indication and uses. So basically, clomiphene is in the class of medication called ovulatory stimulant, and it works similarly like the female hormone, that is estrogen. It is a non-steroidal compound and first drug of choice in ovulation. Indication. It is mainly used in the infertility issues with the and ovulatory cycles, and also used in vitro fertilization and oligozoospermia. And clomiphene is rarely used in males, but sometimes it used to increase the testosterone and sperm count. Contraindication. Patient with enlarged ovaries and patient who have symptoms, visual symptoms associated with the clomiphene therapy. It is also contraindicated in the disease such as chronic liver diseases and brain tumor, and also contraindicated in the breast feeding women or pregnant women. Dose. Clomiphene is an oral dosage form, and the dose is 50 mg per day for 5 days, and on the 5th day of menstrual cycle or at any time if the menstrual period is absent. And the dose may be increased up to 100 mg per day for the second course, and the total maximum therapy is the 6 treatment cycle. Adverse reaction. There are many adverse reactions related to the this drug, like hot flashes, visual symptoms, ovarian enlargement, multiple pregnancy, and ovarian carcinoma, and some other common side effects like headache, nausea, vomiting, constipation, hair loss, weight gain, and heavy menses. Brand name. These are the brands that are basically available in the Pakistan: Clomid, Serpeffer, and Profertil. Alternative of the drug. Two drugs, that is tamoxifen and raloxifene, can be used as an alternative to clomiphene for ovulation indication. Soap notes. Case study. A 31-year-old woman present with the history of infertility of 2 years of duration. Her body weight is 85 kg, and she has a bilateral tubular patency on HSG test, and her husband has a normal fluid analysis. She has also hypothyroidism with hyperprolactinemia, but no galactouria. And treated with the bromocriptine given 2.5 mg twice daily, and levothyroxine given to 25 mcg. She presented with the severe abdominal pain which get worse with time, and she denied sexually transmitted disease. She has an irregular menstrual cycle and have excessive hair growth, usually on her face, chest, and back. Lab result shows that low progesterone level, and that is 1 to 2 microgram per ml, and low anti-Mullerian hormone, and that is AMH, of 0.6 microgram per ml, and the level of prolactin is high, that is 150 nanogram per ml. Subjective. The age of the patient is 31 years old, gender is female, and the body weight is 85 kg. Chief complaint, she presented with abdominal pain and irregular menstrual cycle. History of infertility of 2 years of duration, bilateral tubular patency, hypothyroidism, and hyperprolactinemia. The current medication she is using is bromocriptine, that is 2.5 mg twice daily, and levothyroxine, that is 25 mcg per oral. Objectives. The laboratory data shows that a low progesterone level, that is 1 to 2 microgram per ml, and anti-Mullerian hormone of 0.6 microgram per ml, and the level of prolactin is also high, that is 150 microgram per ml. And the bilateral tubular patency also shows on hysterosalpinography. Assessment. The possible red flags are bilateral tubular patency, hypothyroidism, and hyperprolactinemia, and usually female with these symptoms have mainly the ovulatory infertility, and she has also irregular menstrual cycle and excessive hair growth, which usually shows the sign of polycystic ovary syndrome. And she presented with the history of infertility of 2 years of duration. The progesterone level, that is 1 to 2 microgram per ml, and AMH hormone of 0.6 microgram per ml are low, and the high level of prolactin, that is 150 nanogram per ml. So basically these signs and laboratory data, her obesity, polycystic ovary syndrome, low progesterone, low AMH, will all likely contributing to the ovulatory infertility. Plan. The pharmacological treatment include clomiphene. We start with the clomiphene on the cycle day 3, 4, or 5, usually in the dose of 50 mg daily for 5 days. And then we check the progesterone level on day 21. If not ovulating, then we increase the dose up to 100 or 150 mg per day maximum, up to 6 cycles. And we also continue our previous medication, that is bromocriptine 2.5 mg twice daily for hyperprolactinemia, and levothyroxine, that is 25 mcg for per oral for hypothyroidism. Non-pharmacological treatment. We counsel her on nature of her infertility, and we advise her for weight reduction. References. The material in this presentation was taken from books Lippincott and Koda Kimball, and also taken from these websites. Thank you.